So first, just discussing the relevant treatments and interventions that have been researched. There hasn't really been much data or much research put into RID, just specifically because it is a new disorder that has been a part of the DSM-5. It used to just be a part of attachment disorders as a grouping, but now that it's its own disorder, there's research that is coming out more recently in the last 10 to 20 years. But from the quote above from Driscoll 2019 on page 99, it says, "It seems that improvement takes consistent, emotionally attuned, and extensive loving care by caregivers. Caregivers need ongoing support from mental health clinicians." This seemed to really be the theme, central theme across the board for how treatments go and how interventions go well, that you have to have caregivers who are going to be emotionally attuned and consistent with the treatments in the intervention process, as well as mental health clinicians who are going to be supportive of the caregivers. But with the recent research that has been put out, there are two screening measures to diagnose RID. The first is a relationship problem questionnaire, and the second is a reactive attachment disorder checklist. And both of these were run through a study, and the alpha scores for each at the end presented really strong consistency, which supported the use of both to screen the diagnosis of RID. And so these are used in the treatment process to differentiate RID from other social anxiety disorders, ADHD, mood disorders, things like that. Something that has also come up in the treatment and intervention process are many challenges, because typically a child who is diagnosed with RID also has multiple diagnoses in other areas, whether that's with psychosis, a mood disorder, social anxiety, or personality disorders, because of the maltreatment that is in the home of these children. And it depends on age, it depends on the parental care environment and their trauma history for which diagnoses will also be attached. And the other thing is, because RID is fairly new to the research field, clinicians lack a lot of knowledge of these supported treatments. And so if there's a misdiagnosis of RID and a clinician is diagnosing a child with maybe just an attachment disorder or a social anxiety disorder or bipolar, and the treatments that are that happen because of that disorder, there's a misdiagnosis, and so they don't have the correct treatment. So that's a challenge as well. And as Ashley mentioned in the very beginning, RID has two characterizations. The first is inhibited and the second is disinhibited. The first one just showing a failure to initiate with social interactions, and they're usually inappropriate and really hypervigilant. So these kids will have really a lot of a hard time associating with what is an appropriate relationship, whether that's with a male of a certain age or a female of a certain age or a teacher. There's not really those like social norm boundaries for how to interact in the social environment. And they're also really hypervigilant. So they're always alert and things are always affecting them more so than the average person. And so because of that, it's really hard for them to interact socially. And then the second categorization of disinhibited, they have diffuse attachments that are formed. So these are non-selective. They're really inappropriate and they don't really attach to any specific person based on past history. Typically, if a child is really close with their mom, they might attach more well with women, and then same vice versa with a father, might attach more well with dads or with males. But the disinhibited characterization, an RID patient would have diffused attachments, so they would not be able to select attachments based on past experience. And they're severely inappropriate. They're completely dysregulated. There's not really a way to track attachment to figure out if they're securely attached or insecurely, just because of the trauma history and the differences in ages, and because of the multiple diagnoses. And so next we'll move on to counseling strategies. The quote above from Golden 2009, page 2, this diagnosis is unique in that criteria includes environmental factors, such as pathogenic care due to either emotional neglect, physical neglect, and or multiple caregivers. So as Margot was talking about, there's definitely a really large variety of people, whether that's in impoverished communities and ethnicity, and whether they come out of foster care or through an adoption agency. And so because this diagnosis is so spread out and has to deal with environmental factors such as the people that they interact with and the homes that they're coming out of, the diagnosis of attachment disorders have a lot of issues. So first is the lack of a stable caretaker. Usually these children are in and out of foster care when they're really young. And that is how some of those multiple diagnoses come up, because they either go one way with multiple psychosis or another way with mood disorders because of that neglect. There's also evidence to support anxiety and mood disorders that most kids who are treated with RID will have an underlying social anxiety or mood disorder, just because they're in that fight or flight survival mode at all times. But this disorder does remain stable over time. For what they know research-wise, it does not really look like there are limitations to how this develops, and a stable assessment of when or if it develops, but it is stable over time. So the child will have RID the rest of their lives, and it will affect all of their interactions, just because it is so embedded and because there are usually multiple diagnoses. The age group diagnostics in foster care from the Golden Article was also really interesting to me. It talked about preschool, middle-aged, and high school kids and just the differences in growing up in foster care versus not. Preschoolers have 20 to 40% more likelihood of being diagnosed with a behavioral disorder or ADHD coming out of foster care than someone who did not. Middle schoolers have 16 times the risk of developing psychiatric disorders or ODD, which I thought was really interesting as well. And then high schoolers and entering early adulthood, there is also typically a diagnosis with borderline or antisocial personality disorder. And so just looking at these age group diagnostics, it's really easy to see how difficult it is to diagnose RID, because it really does depend how long the child is in foster care. And clearly it can be stretched, and the child can develop and kind of metabolize a lot of these other disorders and other social anxiety issues that kind of put RID under the rug sometimes. There have also been a lot of other characteristics that I found. Usually there's learning disabilities going on with the child. Sometimes they're on the autistic spectrum. Sometimes there's co-occurring trauma that's going on at the moment. Poverty was a huge theme, and substance use within the family as well. We're all really familiar as far as kids who are diagnosed with RID. And some of the counseling strategies specifically, taking in all of these issues and taking in all of the group diagnostics in foster care, play therapy was found to be really successful with children in that preschool age, just because it was grounding and it was able to give them something to focus on other than everything going on in their lives. And also a personality analysis was also seemed helpful with middle school and high school aged kids, just to get a census of if there is that antisocial or mood disorder going on, or psychiatry, so that they could put RID on top of that. And then also just a knowledge of misdiagnosis. I think that most counselors, it seemed as I was reading these articles, would not diagnose a child with RID just because there would be so much more going on with the anxiety and mood disorders, and so it would kind of get pushed under the rug. And so just a knowledge that it is very common to misdiagnose a child who has RID with something else, and also just flexibility with interventions. A few of the studies that I read, they were talking about these different age group diagnostics in foster care. Preschoolers who worked really well with play therapy, like middle school aged kids did not. And so for a counselor to be really flexible with their interventions and being able to change their path of direction, even if that is something that they believe at the time, just because of misdiagnosis. And then the last thing is to view all of this from a biblical worldview, which seems kind of packed and super complex, because as you can see, this disorder manifests itself in many different ways. And usually there's a lot going on with the child environmentally, their trauma history, their family dynamics that have been passed down, as well as social anxiety, mood disorders, psychiatric and psychosis stuff going on. And so how do we apply this biblically? And I found the verse from Matthew 10:30-31 that says, "And even the very hairs of your head are all numbered. So do not be afraid, you are worth more than many sparrows." In this verse, Jesus is talking to the disciples before he sends them out, and is basically telling them, like, you are known by me, and you will be known by me, and people will know you by me, and you're going to be hated because the world hates me. And just giving them every single piece of advice before he sends them off into the world, but tells them that no matter what people say about you, and no matter how you're stereotyped, or no matter how you're hated or what you're called, like, every single hair on your head is numbered, and I know you better than anyone. So don't be afraid, because your worth does not lie within their words. And this just kind of felt like a verse to apply to RID, and even just specifically all disorders, because I think it's really common to see the person as their problem and not just a person who's struggling. And so I think first, just affirming people and letting them know that they're not defined by their disorder, nor are their relationships, that they can grow and they can change, and that their disorder doesn't define the trajectory of their path. And that also, as counselors, we're anointed and we have this calling to want to help people, but we also don't operate out of a messiah complex, because we don't know everyone's situations and we don't know everything that's going on. But we can also have confidence in the clinical training that we have and the compassion for people to walk alongside them at the same time. And because we touched on RID looking like ADHD, looking like mood disorders, looking like so many different things, the Lord knows the in and outs of every single person and the complexities of the brain. We're not even aware of half of the thoughts we think, due to the unconscious mind and just all of the wirings going on that are both genetic and predisposed, and just so much going on. And so when it comes to disorders like RID that are manifested out of so many issues and such a history of trauma, the Lord knows all of that. And so if we can be attuned with the Holy Spirit and just listen to how the Lord wants to move us to walk with these people, I think that that will help our flexibility to change the course of treatment and be open to the intervention process. And that if we do misdiagnose a child who has RID with something else, we're able to be flexible and change our course of treatment and give them what they need. So that is sort of the end of our conversation around RID and implementing the biblical worldview. And I will turn it to Ashley to conclude us.
Thank you, Bridget. In conclusion, it is evident that RAD needs more attention than it has been given. It is exemplified within the counseling world and is necessary of being able to diagnose this disorder by thorough interventions and detailed history evaluations. Our group believes that there should be more research on the minority population section. There has not been much research done with RAD as a whole, but it would be beneficial to explore it and explore gender and environmental location. And if that has any part and any effect to this disorder, and pursuing more research within that. We also thought some good populations to research would also be how children turned out who have divorced parents or even drug addicted parents or caregivers, to see how their attachment and bonding was affected by that. Treatments will continue to grow and develop the more we see this disorder come into play. RAD is hard to diagnose, but the more we see it and the more research is done, we can do a better job at noticing someone with RAD and their unique treatment necessary. That concludes our presentation. Thank you for listening.